good, Doc. Hang in there. You're doing fine.
Have him come up and go over what lab therapy is and how it can help, and he'll be happy to answer any questions and be here as long as you need him. So without further ado, here's Dr. Dean.
Good morning.
Good morning.
I know I got y'all scattered all the way back there, so I'm going to ask you if you'll just come on up. Just come on up here in the front and we can get real cozy and comfortable. It doesn't, just a few steps. Thank you. There you go. Come on, Roger, you can do that.
Yeah, I can do that.
You just didn't want to. You just didn't want to get that close. He knows I'll pick on him out there.
Right up here.
Sure, we'll get right up here. The reason I want you to come up is we've got some things I want you to be able to visually see here, and we'll talk about them a little bit. I think it'll help maybe you understand a little bit more about why lab therapy can do what it does. First thing, now, what of course we're going to be talking about today is lab therapy. And lab therapy stands for lumbar axial distraction decompression. And the idea behind lab therapy is to distract the lumbar vertebra to the point that it affects the disc, creates a negative pressure inside the disc. When that negative pressure is created, it basically creates a vacuum and starts to suck a herniation or a bulge back into or back to the disc. That lets the outer core of the disc heal itself up naturally. We'll talk a little bit more about that later. Basically, I'm going to give you a real quick anatomy lesson. The spine is composed of several bones, or small bones, called vertebrae. And they're mainly the central core of your spinal system, okay, of your body. In one way or another, every tissue, organ, or bone hooks onto the spine. So it's real critical for us to be able to give a symmetry to our entire body system. Now, in between each one of these bodies of the vertebra is a little pad. It's called the disc. It's a shock absorber system for the body. The outside portion of the disc is called an annulus. And it's composed of several layers, kind of like an onion skin, if you can imagine that. What happens with that is each one of those layers lays at about a 30-degree angle. The fibers in those layers lay at about a 30-degree angle, and they attach to the tops and the bottoms of the vertebrae from below. So you have one layer going one way, one layer going the next way, and it just continually has some concentric rings like that. Well, those fibers, when they attach, give our spine, give our body a lot of tensile strength. So what that does is when you bend one way, then the fibers go in that direction, opposite direction, hold on to the vertebra. When you bend the other way, then you got strength going the other direction. Sometimes what happens is those little fibers, because of micro traumas or stresses or little tears, they can separate. What that does, that weakens that annulus. And most herniations don't come from a single incident, like a fall or a trauma or a car wreck, but they happen over time. The annulus gets weaker and weaker, and eventually it lets the inner core, which is the nucleus pulposus, or the nucleus, to bulge out. Now the nucleus is kind of like a gel material. It's about the consistency of grape jelly. And it's the pivotal point that the vertebrae rotate and move on top of each other. And it's under tremendously high internal pressure. So when those fibers of the annulus get weak, they allow that inner core to push out. You kind of get an idea here. I hope you can see this pretty well. This is a normal lumbar disc. This is the back of what we call the spinous process. That's your backbone, those little clumps you can feel back there. This would be the spinal cord. You can see it runs right next to the vertebra. These are the major nerve trunks called spinal nerves that exit in between the holes of the vertebra, which are called foramen. Now, this is the disc. That's that little shock absorber pad. This outer core in blue is the annulus. You kind of get a representation of those fibers or those layers in there. This orange color would be the nucleus. And as long as everything's sitting just about right, then it acts very well to help support our bodies and give us that springing or that shock absorption system. Now, there basically is two different kinds of herniation or disc bulge. We have a contained disc, which we call either a disc bulge or a protrusion. And what that is, it's when the nucleus, or that inner core, that gel-like substance, pushes the annulus out. It's still within the annulus, it's still contained inside the disc, but it can bulge out and compress on the nerve trunks. Of course, that can produce back pain, leg pain, numbness, tingling. I know everybody's heard of sciatica, how it goes down the back of the leg. Well, it can go all the down to the foot, because these nerves from the lower part of your spine control everything from your abdomen all the way down to your toes, including all the internal organ systems. That's called a containing disc. Now the second thing, which is a little more serious obviously, is called a non-contained disc. That's called a prolapse. That's when the outer core, or the annulus, the fibrous, is actually torn apart, and the inner core, the nucleus, actually squirts out. Sometimes we call that a sequestered disc, because that portion that squirts out sometimes can separate, and it can slide up or down the spinal canal. It causes a lot of problems, and usually that's the reason for a surgical consult when it's absolutely necessary. Now, the Spine Institute of San Diego, which is one of the largest spine care clinics in the world, basically said of the 250 to 300,000 back surgeries that are performed each year, about 90% of those can be avoided and not have to go through surgery through conservative means. So if you think about it, if we're doing 300,000 surgeries a year, that's a lot of backs getting cut on. That's a lot of backs getting cut on. There's also kind of a thought that goes around that the number of back surgeries in the United States are directly related to the number of back surgeons. So the more surgeons you have, the more surgeries you're going to get. Now there's basically, with some variations, 3 types of disc bulges or herniations that really can occur. You can have a central herniation that can produce a bulge that goes straight back into the spinal canal. It can affect the spinal cord itself and cause bilateral problems. It can cause back pain, buttock pain, or pain that goes down both legs. Sometimes we see that. Most often what we see is because the anterior and the posterior ligament, they're called the anterior posterior longitudinal ligament, and they're very strong. They attach to the front of the vertebral bodies, they attach to the discs, and they help hold that disc in and give it a lot of support. They're weaker in the back than they are in the front. It's much thicker in the front. So when that disc bulges or herniates, most of the time you'll get a far lateral herniation or even a posterolateral herniation. It tends to affect one side only. It can affect either the left side or the right side. And that's when these people get the back pain, they get the leg pain called sciatica. And again, you can end up with a disc prolapse when the nucleus actually tears and you get a piece or sequestration of that nucleus that can slide up and down. It can cause a lot of problems. Now what we're going to do is just talk a little bit about LAD therapy. What LAD therapy was designed to do is to produce a controlled distraction decompression of the vertebra. What that basically does is as the vertebrae are separated, as they're pulled apart, since there's an attachment of the disc to the bottoms and the tops of these vertebrae, it pulls that disc apart from both ends. When that happens, produces a negative pressure inside the disc. When that negative pressure happens, the nucleus is sucked back in or pulled back in, and it allows that bulge to be pulled away from the nerve trunk. When that happens, it allows the nucleus to be pulled back in, the annulus starts to heal up on its own, the pain goes away. It also provides for a pulling in or an influx of nutrients and fluids into the disc. Most disc herniations happen because the disc has gotten degenerative. And usually that's because of our sedentary lifestyle and micro-traumas over long periods of time. The weaker that disc gets, when it gets a little bit brittle, it's far more susceptible to break or to tear. What the LAD therapy does then is as it pulls that vertebra apart and puts pressure on the sides of the disc, creates a negative pressure, pulls fluids and nutrients back into that disc to help heal it up. Now, the LAD therapy basically consists of 20 sessions. What we do is we place a pelvic belt, very comfortable pelvic belt, around the hips, and then we have a chest restraint that holds the chest in. Then we place you on a specially designed split top table. What that does, it allows a reduction or elimination of the friction resistance between the table and the patient. So once the treatment starts, as the computer pulls the low back, what you feel is kind of a real strong but pretty much painless pull on your lower spine. And we start at a very low level, and then we work up till we actually get the vertebra starting to separate. When we do that, we start to affect the disc. Then it pulls that disc protrusion away from the nerve, the pain starts to go away. Actually, we got one of our patients here that's been through the process. I'm going to ask him if he would just not mind to come up and tell you about his experience with LAD. Then we'll show you what the belts that look like. try to answer any questions you might have. Steve, if you wouldn't mind?
Type of bulge that I had was this one here. Thank goodness it wasn't this one. So mine was L5S1 and L4L5. And of course I went through all the drug treatments, the Celebrex and the Vioxx, and that does help you make it through the night because the pain will go away. Because as that bulge comes out, the first thing it's going to hit when it goes out the back is your nerves. And so you can tell basically which disc is having a problem based on where the pain is. Of course, mine was coming all the way down, so they knew right away. The worst one I have is L5S1 because it's degenerated quite a bit. But the L4, L5 also had a protrusion. So I had gone through the physical therapy. That didn't do me. That actually made me feel better for a while, but it was never going to fix it. It strengthened my stomach. It strengthened my back muscles. I think over a period of time, my back muscles just stopped working because that's how that allowed that disc to bulge out that way. Because I wasn't doing anything but working in the yard, and then it was all over with. I mean, you couldn't lay down, you couldn't sit. I mean, all the way down to the back of the bottom of my heel. It's like when that disc bulges and hits that nerve, that thing causes all the nerves all the way down your leg to start firing. And then that's like you tired out that muscle, like you really exercised it and to get to that point. So I went to the regular doctor first and got the drugs. That helped a little bit. Then I went to the physical therapist. Well, actually I went to is he a neurosurgeon? That we say.
Yeah.
Dr. Luke Knox over here, real nice guy. And he sent me over to physical therapy. And after about a month and a half of that, I came back and he said, well, you know, there's a couple of things I can do for you. Is I can take these vertebrae right here and take that disc out and fuse them together. I said, well, you know, that's pretty drastic, isn't it? He said, well, that's how I can take care of the pain. So if I don't have this bulge hitting the nerve, I don't have the pain. And so his method of taking over pain management is get rid of that disc and bring the two together. And of course, they got to graft bone from your hip. They got to come in and cut you wide open, about the size of your fist, so they can get down in there. And then of course, you've got that recovery thing. Well, I didn't want that. And I asked Dr. Knox, I said, well, is there anything else? He said, well, you can go back to your chiropractor. Well, I've been going to, this clinic was before Dr. Masters, it was Dr. McCluskey. And I've been coming to him forever, just for normal maintenance stuff. So I came back and this guy had showed up. And he says, I got something that can help you. And I says, here's my money, let's do it. So I did it very quickly. I did it over 4 weeks.
4 weeks.
So I came every day for about an hour, hour and a half a day. The reason was that during Christmas time, I was supposed to have a month off down in Florida. And that got all messed up. But anyway, that's the reason I tried to do it real quick. And after Christmas, I came back and I had maybe 3 or 4 more treatments. And I have not had any leg pain since about the first week in January. I mean, I have to be real careful. I'm steady exercising, trying to build those muscles back up. Because he can only take it to a point. I've got to take it the rest away. I've got to be real careful so as not to re-injure it. I believe what he's done for me is gotten this disc and bulge away from that nerve. Otherwise, I'd still be having the pain. So it's basically when he straps you in and starts pulling it apart, he started at 90 pounds on me.
On you.
I'm right about 200 pounds. So he started at about 90 pounds, and when I was to about the 18th or 17th treatment, we were up to about 145 pounds. And what that was doing was, and you can feel it. You know, it's real subtle. They pull you apart for 60 seconds. I'm going to let you back in for 30 seconds and then pull back out. And then after you get off of that machine, you get some what he calls interferential electrotherapy. That helps quite a bit too, because I think that goes down to the tissues that I can't reach. I mean, people can massage you and you can stretch your own back, but this electrotherapy gets me all the way down to those tissues. And I think that helps quite a bit too, because it stimulates those nerves and those tissues. And if this thing can recover, if it can keep itself back in, then, you know, that's the reason I won't have the pain again. And I look real hard at the Benatti. And, you know, I ended up doing this. I thought, okay, here, if I do this and it doesn't work, then I can go to Benatti. And then if Benatti doesn't work, then I can go back to the guy and he'll clamp it down. And the rest of my life, I'll be worried about the disc right up above it. Because as soon as they do this, as they fuse it, then the disc above it's got to take all the action and all the trauma that the two have been doing. So that's the reason I've been really, and I'm only 46, going on 47, so I'm thinking, but my lifestyle is I'm a computer programmer, and I've been that for 27 years, and it's like, well, you know, get a real life and you won't have to do that. But that's how I make my living. So didn't want to go through the reconstruction part, and, you know, sometimes that recovery time's 4, 6, 8. How long did it take you to recover? Well, I like the Benatti idea over everything else that I've researched and looked at, because it's so non-invasive. The way they talk about that is but what they're going to do is they're going to cut some of that disc away. So when I found out his option, I'm going, hey, they're not cutting anything and they're not fusing anything. Let me try this first. So far, I found some wood somewhere. It's working so far. So I'm really happy the way that's, you know, the end result has occurred. But I still got to keep it going. You know, and I have to be real careful. And I don't know, you think it'll, you know, maybe a year from now I won't have really any pain, or?
I think that's very unusual. Because there's definitely a healing process that has to go on, even once you correct the disc problem. It has to re-heal itself, because it had to get to a point that it failed in the first place. So even if we correct that disc problem, it has to go through a healing process, and usually that's through the rehabilitation and the nutrition and the exercise programs that he's doing. Thanks. Appreciate that. Thank you very much.
You want to check that out?
I can, yeah, while you're here.
Okay.
I'll just give you a kind of show you what these belts look like. They're fairly comfortable. Steve doesn't think so.
Kind of medieval, if you want to know the truth.
But this is
Shannon comes in there with her whip.
This is the thoracic belt. You're a big help today.
I think we're good.
Okay. We'll put this on.
But now remember, I'm laying down.
Yeah, he's actually on the table when he does this.
Then he takes your breath away.
Yep.
Like that.
This is a padded belt. Okay. What we basically do is we put it so that it catches the rib cage and just holds the rib cage in place.
He says he can't breathe, but most of the time he can.
All right. This is the pelvic belt. Twist it a little bit. This goes on just like a girdle, or similar to a girdle. I wouldn't know. You wouldn't know. We're not going to lock him all the way up into this thing. And these attach to the top of the table, which is immovable. The upper part of the table just stays stationary. The lower part of the table is the portion that moves away to affect the lower back. In the back of this, let me turn you around a little bit. In the back of this is an air bladder, which we inflate to maintain the normal curvature of the lower back so that we're affecting the disc that we're trying to affect. And depending upon the direction of the pull, the angle of the pull, we can just about center on any particular disc that's having a problem and affect just that disc. Now, there's override. It also affects the other discs, but that's not bad. That's really good, because it also increases the amount of nutrients and fluids going into all the discs in the lower back, which helps maintain their health. And then, of course, this attaches here, so the belt is very secure.
That inflates here on the back?
Ma'am?
That inflates on there
Yes.
on the back?
Have an air bolt here that we just kind of pump it up to tolerance level, so we're just maintaining that curvature. We don't flatten it totally out. It's a fairly comfortable process, although it's a lot of pressure in there. So we want to affect the pressure because we want to decrease the pressure inside of that disc. So let me just give you a tiny bit of history on me. In 1968, I'll do this real short. 1968, I was involved in an auto accident. I injured my low back and, of course, my neck. I got hit from behind. But I thought I healed up pretty good. Well, I was only about 17, 18 years old, and after I got better, I thought it was kind of a hoss, and one day a bunch of us are out messing around, and I tried to lift the front of a Volkswagen off the ground. Shouldn't have done that, but we were all trying to show off to each other. When I did, I really hurt my lower back. I got the leg pain, I got the numbness down my left leg, it was constant, it was severe, and I'd started college, and what I was having to do every day was I would take anywhere from 3 to 4 150 milligram Darvons at 4 o'clock in the morning. I'd wake myself up, take 150 milligram Darvons, so I could go back to sleep and then wake up in time to get ready to go to college over in Northeastern Tahlequah. At noon, I would take another 2 or 3 of those painkillers just to be able to make it through the afternoon, and then at night I would take a couple of 3 so I could go to sleep. I was going through over 150 milligram Darvons a month. I was just living off the painkillers. Well, my mother, of course, was very concerned. She took me to several doctors, and they basically did the same thing. They either give me painkillers, or they give me muscle relaxants, or they tried to send me to physical therapy. They even put me through traction, and none of it helped. Well, in 1974, I was just pretty much at my wit's end, so I went to another orthopedic surgeon, and he said, well, let's put you in the hospital and do a myelogram. And I don't know if you know what a myelogram is, but essentially they take a needle that's about the size of a telephone pole, and they put that in your spine, they withdraw the fluid from your spine, and they put dye in there, then they take x-rays of what's going on in your spinal system. Once he did that, he came back in the room where I was, and he said, well, you have a herniated disc, we need to do surgery. Well, I was 18 years old. I said, I don't care, let's do whatever we gotta do to stop it. So we went through the surgery, and for about 2 weeks I felt pretty good. Then the pain all came back. I was actually worse after the surgery. Well, it was just my good fortune that after I'd gotten through my undergraduate studies, I was working as a psychologist at a children's institution, and one winter it iced up really bad, and I slipped on the steps going into one of the dorms where the kids were. Well, I slammed against the door frame, so for like 2 weeks I walked around with my head on my shoulders. I couldn't move my neck. And my mother said, well, I'm going to take you to my chiropractor. I said, no, you're not. I'm not going to go to a chiropractor. I'd heard every horror story in the world about him. Anyway, she took me to the chiropractor, and he started working on my neck, and it got better. But then I started telling him about what I'd gone through with my lower back and the surgery and all the medications and the whole mess, and he said, well, let's have a look. So he started adjusting my lower back after that, and it progressively got much better. Within 6 to 8 weeks, I was in pretty good shape. I rocked along there for a long time, and that was enough of an influence on my life that I decided to not work on my PhD in psychology, which is where I was headed, the University of Arkansas. I went back and went to undergraduate school and went to chiropractic college, got real involved with it. So I treated people for several years, did very well. I mean, I'd have to have adjustments every once in a while. But then in 1995, I made another big mistake. I helped lift a big roller table that we had, weighed about 300 pounds. I moved it and kind of lifted at the same time, and I re-herniated L4-5, and I herniated L5-S1. I was absolutely determined not to go through surgery again. It had not worked before, and statistically, only about 50% of all back surgeries are effective, which means about half of the people, half of the time, are not going to get results. Or if they get them, they're going to be marginal results. Besides, it's invasive. Surgery can produce epidural adhesions, it can produce scar tissues, which is going to recreate the problem. There's a potential for medication problems with the surgery. There's a potential with cutting the blood vessels or the nerves. So it's just not a real good option. So I spent about 2 years researching every possible option that would be conservative that might be able to treat herniated discs. From all of that research I gathered, I came up with lead therapy. It's the most conservative method there is available to treat a herniated disc. And it works. So far, since 1997, we've had about an 80% to 85% success ratio with it. That's good odds. And it's non-invasive. Yes, sir, you have a question?
If I may.
Yes, sir.
When you had your back surgery for the first herniated disc,
Yes, sir.
did they remove part of that disc, all of that disc, or
They just
just
took a
the
portion. They did-
protruding part, or what?
Yeah, they did it. They did what's called a disectomy. They just basically went in like Steve was talking about, and they cut that portion off.
The part that was protruding?
Yeah, the part that was pushing on the nerve trunk.
Mm-hmm.
And it helped for a little while. It helped for a little while. The problem is that in any surgery, I don't care what kind of surgery it is, but especially with back surgery, how that heals up is with scar tissue. That scar tissue can affect the nerve trunk, it can wrap around the joint, invasive, and that's why several people, I mean, I've talked to tons of people that have been through surgery that have had to have a second or a third or even a fourth. We had a gentleman in here, Tuesday night, that said his son's been through 2 microsurgeries and they refused to do him again. They refused to do it again. It's not working for him. Well, there has to be another alternative. So what I did is, with all my research, I looked at every possible avenue there was, and the idea behind traction has been around since, Middle Ages. I mean, they used to strap people on ladders upside down, and then they pull them over the top of a house with a pulley, and then somebody let go of the rope, so they fall down to the ground. I'm sure you've seen these in movies, but these big wheels, they would tie people to big wheels, and they would turn the wheel to try to do a traction process with them. So the idea has been around forever and ever. The difference is we've taken traction to a whole new level. We've taken it to a distraction, decompression process. Because traction hasn't worked since, I mean, the physical therapists have been using traction since the 30s, 40s, and 50s, but it just never worked very well. The main reason is because basically all it did was stretch the muscles. It never got to the ligament structure, which holds the bones together, and it never got to that disc. And until you affect the disc, you don't have any response. Okay, I'm going to open it up. Anybody has any questions? I'll do my best to dodge them.
What does
See what I can do.
LADD stand for?
Sir?
What does LADD stand for?
It stands for Lumbar Axial Distraction Decompression Therapy. Actually, I've got some handouts. We'll pass those out. And it just kind of tells you a little bit more about it. Yes, sir.
Evidently, I thought you started at 10 o'clock.
That's our fault, sir. We two different things went out. One said 9:30, one said 10. That was entirely our mistake. I apologize for that.
We can do some backtracking.
So are you gonna have another seminar today?
We're planning on doing another one maybe in another month.
Well, they called me the phone and said it's 10 o'clock this morning.
I understand. I apologize for that. That was just a glitch.
All right, give me, first talking about back surgery. I had one, that's the only successful operation I had. It was a total fusion.
Fusion?
And now my back's going above that point. Now I'm having the same problem you had before.
That's exactly what Steve was talking about. Again, you know, I'm not absolutely opposed to surgery. I mean, if somebody's in intractable or severe pain, or if they start to have bladder problems or bowel problems, sometimes surgery is absolutely necessary. But I think almost any surgeon that you talk to, the basic consensus now is that everything should be tried conservatively before surgery is attempted. You should go through every process that's available before surgery is done. And most of them recommend at least 3 months of conservative treatment before a surgical consult is made. That's exactly what Steve was talking about. Whenever they fuse 2 vertebrae together, I mean, if you just think about it for a second, the vertebrae are designed to move. They are designed to move. That's what they do. They allow us to bend and twist and turn. And they sit on top of each other with joints. And if those joints are locked in place from a fusion, then all of that motion has to be transferred to the disc and the joints above or below that level of fusion. Sometimes it stops the pain, but it causes more problems on down the road. Because now that disc that's above where you had your fusion, it's taken all the abuse, it's taken all the stresses that your body places on it, and you've lost that motion in that fused area. So I've treated several people with light therapy that have been through prior surgery. A lot of them are called failed back surgery syndromes. And we just got really good results.
Well, if you had missed this point, you say a chiropractor can actually improve
I didn't.
ruptured disc?
I still misunderstood your question.
So you're saying chiropractic can improve the ruptured disc, get rid of the pain?
Not chiropractic so much, but lead therapy does. It can stop the pain.
Is all that information in here?
It's all pretty much in there. Yes, ma'am.
Are you Dr. D?
Yes, ma'am. I'm Dr. D. Sorry. Yeah, I think you came in late because you got the other information. I apologize for that.
The doctor in Florida, he's actually unfusing this.
So they started doing that now. They started taking that fusion away because they found out that it just wears the whole lower structure out. And your lumbar spine supports all your body weight, so it's gonna take the most abuse anyway. And I've heard of them going in and taking off those fusions, and now they're using like a little plasticized or plastic disc to replace these discs. Any surgery is invasive. Any surgery that's done has potential for a huge downside. I mean, you know that. I mean, anybody want to go to surgery? No, I don't either. I don't either. If that's the only option I got, then okay.